Welcome to Breast Cancer Breakthroughs. Some truly exciting advancements in breast cancer research were recently announced at the American Society of Clinical Oncology 2023 annual meeting, also known as ASCO. Today, we will give you an overview of 3 exciting trials presented at ASCO, and then do a deep dive into the SONIA Trial, one of the more controversial breast cancer trials announced at ASCO. We'll hear from outstanding medical oncologist Dr. Erika Hamilton and former Komen grantee Dr. Sherene Loi, who attended and presented at ASCO, and they will discuss why it's important for patients to know about these clinical trials. The NATALEE Trial, one of the most hotly anticipated trials at ASCO, was considered a big win for patients, particularly those with early breast cancer. CDK4/6 inhibitors received a lot of attention at this year's ASCO meeting. CDK4/6 inhibitors are the standard of care for metastatic estrogen receptor-positive breast cancer, but what about for early breast cancer patients? While 40 to 70% of patients with estrogen receptor-positive breast cancer will be cured with endocrine therapy alone, the remaining patients are at risk for recurrence. Currently, the only option for those with a high risk of recurrence is chemotherapy and an extended course of hormone therapy. In the NATALEE trial, researchers set out to see if a CDK4/6 inhibitor called ribociclib can be combined with hormone therapy to reduce the risk for recurrence. They found that ribociclib combined with hormone therapy decreased the risk of breast cancer recurrence compared to taking hormone therapy alone by 25%. Let's hear what Komen grantee and co-author on the trial, Dr. Sherene Loi, had to say about this.
The most exciting things I've seen at this year's meeting is one, the phase 3 readout of the NATALEE study. So that was a CDK4 inhibitor, ribociclib, in the early stage setting with endocrine therapy. This was a positive study in that the combination of CDK4 inhibitor improved the risk of recurrence compared with the endocrine therapy alone. So this is a great win for patients. The data is still early, of course, because 80% of patients still remain on therapy. So we'll wait to see what happens in a few more years. But this is great for the field because the CDK4 inhibitors have been around a long time in the metastatic setting and have improved overall survival. And we've been a bit disappointed with the results of the palbociclib studies, but we were buoyant with the results of the MONARCH E studies, which looked at another CDK inhibitor, abemaciclib. So that was also a positive result, and that also reduced the risk of recurrence for breast cancer patients in the early stage setting. So we're hopefully that we will get more cures.
Thank you, Dr. Loi. These results are very exciting for patients. The next trial to make big news was for patients who are estrogen receptor positive or those with triple-negative breast cancer. This was a phase 2 trial evaluating HER3-DXd, a new antibody-drug conjugate treatment in metastatic breast cancer. If you remember from our first episode, antibodies are sticky proteins that help us to target specific cancer cells while attempting to spare most of the normal non-cancerous breast cancer cells in the body. You've also likely heard of HER2, which is one of the ways that we categorize breast cancers. But researchers are also interested in targeting HER3, which is a similar biomarker found in 20 to 40% of all breast cancers across subtypes, and HER3 is associated with poor outcomes. In this trial, 60 patients with estrogen receptor positive or triple-negative breast cancer received the HER3-DXd drug for about 5 months. Here's more on the outcomes of this study and what we can expect from HER3-DXd in the future from Dr. Erika Hamilton, who presented this study.
We presented results from the HER3-DXd or patritumab deruxtecan at ASCO this year in 2023. In this first 60 patients that we enrolled, the overall response rate was 35%, which was really quite encouraging in patients that had seen an average of 3 prior regimens. And we really wanted to figure out whether HER3 expression mattered for response rates and also how patients with kind of traditionally classified triple negative or hormone receptor positive disease did on this drug. The main takeaways from our data with patritumab deruxtecan or HER3-DXd really was that overall response rate and clinical benefit rate looked encouraging across both hormone receptor positive and triple negative breast cancer. One of the big questions that we really sought to answer, and is a very big topic in antibody drug conjugates right now, is does how much antigen expression a cancer cell has matter? Meaning, what's the threshold for HER2 expression? We know TROP2 we don't measure to give a drug like sacituzumab govitecan. And what we found for HER3 was similar, that patients that had HER3 low expression or HER3 negative expression did no worse than those patients that had HER3 high expression. So really telling us that we probably don't need to measure HER3 expression to determine who may be eligible for this drug. So where we're going from here is we're actively enrolling in Part B and Part Z. Part B is going to enroll a cohort of patients that have triple negative breast cancers and a cohort of patients that have hormone receptor positive breast cancers, irrespective of HER3 expression. And we'll also specifically be looking at patients that have already seen a different antibody drug conjugate. So getting at that question of resistance or sequencing one antibody drug conjugate after the other. And so these patients will have seen trastuzumab deruxtecan, our HER2 targeting agent, or sacituzumab govitecan, our TROP2 targeting agent. And then in Part Z, we're enrolling patients that have HER2 positive breast cancer, and we're enrolling patients that have already seen trastuzumab deruxtecan. So really, in the end of this study, we're really getting at resistance and sequencing and what's the activity of antibody drug conjugate after a different antibody drug conjugate.
Thank you very much to Dr. Hamilton. For more information on antibody drug conjugates, check out a clip from the previous episode of Breast Cancer Breakthroughs, where Komen scholar Dr. Sarah Tolaney describes how antibody drug conjugates work, and we've linked this in the description below. One big win for patients was a study that showed some patients need less chemotherapy to have the same outcomes. This trial is one of several trials designed to de-escalate chemotherapy for patients with HER2-positive breast cancer. Researchers are using a new method of imaging to determine if patients respond to HER2 targeting therapy prior to surgery. And if these people do respond to this treatment, they do not receive chemotherapy after the surgery. The researchers found in this study that this approach was effective in pinpointing the patients who can safely skip chemotherapy and all of the awful side effects that go along with it, which is a major win for patients and has the potential to change the standard of care for the people who qualify for this. For more information on chemotherapy de-escalation, we've linked a clip from our previous episode of Breast Cancer Breakthroughs that dives into this concept. We're going to be discussing one of the more controversial trials presented at ASCO, which is the SONIA Trial. CDK4/6 inhibitors have been hugely successful in treating metastatic estrogen receptor positive breast cancer, but a long-standing question has been whether or not they should be used as a first-line therapy, which is given first for a patient's treatment plan, or as a second-line therapy, which is where people receive a new drug after their first treatment regimen fails them. This question is important because although these drugs are approved for both first and second-line use, there have been no studies which directly compare which treatment strategy is most effective. This phase 3 trial was conducted in the Netherlands and recruited 1,050 patients with metastatic estrogen receptor positive breast cancer, which means that their breast cancer has spread throughout their body. The study looked at two important treatment approaches. The first is limiting hormones that drive breast cancer growth and progression using hormone therapy. The second is preventing breast cancer cells from dividing using CDK4/6 inhibitors. Patients were randomized to receive one of two treatment approaches, which is either the standard of care or the standard of care plus fulvestrant. The first group focused on getting the treatment earlier and received aromatase inhibitors, which is a kind of hormone therapy, plus CDK4/6 inhibitors first. The second group received the standard of care therapy, and then they received the CDK4/6 inhibitors after their disease progressed. They found that there were no differences in outcome when CDK4/6 inhibitors were given as a first-line or a second-line therapy. But they found that the patients who received them as a second-line therapy did not need to take them as long as those who took them in the first-line setting. And these people had fewer adverse events or negative reactions to a drug, which can range from anywhere in severity from feeling mild nausea to acquiring heart or lung damage. An additional win of the study and the findings were that due to the shorter time needed for taking CDK4/6 inhibitors as a second-line therapy, the researchers estimate that this led to cost savings of about $200,000 per patient. Now, this all sounds great, doesn't it? However, there are some caveats. We spoke with Dr. Erika Hamilton about what patients need to know about this study and what some of the concerns are surrounding the findings.
There were still, I think, a lot of questions left in many of our minds after the presentation of this abstract. I can name just a couple, points that I think a lot of people were considering. First, to me, it looked like in the first line that the standard of care arm, aromatase inhibitor alone, did a little bit better than we would have expected. So most of our trials are about 12 months with AI alone, about doubling 24 months with CDK4/6. And for some reason in their trial, AI alone did well for 16 months. So we lost a little bit of perceived benefit there. Their trial really wasn't that large. They had about 500 patients in each arm. So compared to the body of evidence we have with overall survival for CDK4/6 inhibitors among multiple trials in the first line setting with, each trial having 5,000, et cetera, patients, this really was a pretty small trial. The trial was actually powered for superiority, but they kind of reported it as inferiority. And so there's a little question around the statistics there. And then, just looking at the curves for me, it did cross one. It wasn't statistically significant, but there was a little bit of a trend towards patients that had CDK4/6 inhibitors up front doing a little bit better. And so when you put all that together, I don't think that necessarily this is going to be practice changing in the United States. I think it may be in countries where they have less access to drugs, where cost of care is a really big issue and can really determine approval and reimbursement strategies. But I'm not 100% sold based on this trial that we should not be continuing to give CDK4/6 inhibitors upfront in the first line setting. I think, to really change people's mind, ultimately, we're probably going to also need a trial that wasn't palbociclib. Certainly, palbociclib is the one CDK4/6 inhibitor that we have that hasn't shown overall survival. So for this study to be based on palbociclib, I think many of us wonder maybe if we would have seen something different with abemaciclib and ribociclib. So really putting everything together, both the fact that the CDK4/6 patients up front did a little bit better, the fact that it was a small trial, the fact that the control arm performed a little bit better than we would have thought, and the fact that it was a palbociclib-based trial when really we tend to probably be using less palbociclib now first line, leaves a lot of questions in people's minds.
While the results of the SONIA trial were interesting and warrant further conversation, it is still unclear who the ideal candidates are to receive CDK4/6 inhibitors in the second-line setting. Now, not to be redundant, but our mantra is, as always, more research is needed. We encourage patients to discuss with their doctors about the course of treatment that is right for them and to consider clinical trials as an option. Below in the description, we've also linked an article featuring Komen grantee Dr. Daniel Stover, which discusses more of the strengths and weaknesses of the SONIA trial. Thank you all so much for watching. Here at Komen, we are committed to bringing you evidence-based information to empower you as you navigate your journey with breast cancer. Don't forget to sign up for reminders about breast cancer breakthroughs. We've linked the homepage below. And if you're interested in participating in a clinical trial, check out our tool for choosing a clinical trial that's right for you, which is also linked below. Thank you, and we'll see you next time.